Hello, I'm Dr. Erika Hamilton, and I lead the breast cancer research program at Sarah Cannon Research Institute in Nashville, Tennessee. Happy to join you guys today, and we'll be talking about PROTACs or proteolysis-targeting chimeras. I'm certainly looking at these in a variety of cancers, but I think we may be the most ahead in breast cancer. So first, we're going to be talking about ER-targeted therapies. You may not be familiar with PROTACs, how these differ from other novel endocrine agents like SERDs, for example. We are going to go through a little bit of the SERD data, specifically dive into the two PROTACs that are currently in clinical development and enrolling patients on clinical trials, and then where we're going from here in terms of clinical trials, and then we will wrap up. So first, let's talk about really how these work. So in panel A, you see estrogen binding to the estrogen receptor and then really moving across to the nucleus and interacting with DNA, leading to gene transcription, ultimately cancer cell growth. In panel B, you see how aromatase inhibitors work. They happen and work very early, really to prevent the conversion of normal body steroids and androgens into estrogen. So the aromatase inhibitors, no estrogen to bind to the estrogen receptor. In panel C, you see SERMs, or selective estrogen receptor modulators. They're the little yellow circles, and they too bind the estrogen receptor, but they lead to a different conformational change and ultimately don't lead to the gene transcription and cancer cell growth. This is why SERMs can be agonistic in some tissues and antagonistic in others. So agonistic in the uterus, for example, antagonistic in the breast. And over in D, these are SERDs, so selective estrogen receptor degraders. They too bind the estrogen receptor, but ultimately lead to flagging the estrogen receptor as a foreign invader and leading to degradation, or as I like to tell my patients, chewing it up and spitting it out. So let's talk about SERDs. First, these are oral now. So unlike fulvestrant that's intramuscularly administered, this is a pill that patients can take at home, certainly a little bit more friendly. They also have higher potency than fulvestrant. They have activity in both ESR1 mutant metastatic breast cancer, as well as ESR1 wild type, although we've seen greater activity so far in those that have ESR1 mutations, and certainly has activity post-CDK4/6, where we really have an unmet clinical need, where a drug like fulvestrant in a post-CDK4/6 setting is really only giving us a progression-free survival of less than 2 months, which clearly is not good enough. So our current FDA-approved oral SERD is elacestrant. And this was the EMERALD trial. It was a phase 3 randomized trial, very straightforward, elacestrant versus standard of care endocrine therapy. And the majority of patients that received standard of care endocrine therapy did receive fulvestrant. In terms of who was enrolled on this trial, a little less than half had seen 2 prior endocrine therapies, so 2 lines in the metastatic setting. About a quarter had seen prior chemotherapy. Most patients had visceral metastatic disease, and about half had ESR1 mutations. If you look on the left side of the screen, you see the intention to treat population, and this was a positive study. You can see that the PFS improved from 1.9 to 2.8 months, but I think we all kind of ask ourselves, okay, well, it was positive, but it's a 1-month benefit here. On the right, if we enrich for those patients that have ESR1 mutations, you can see that we kind of double that benefit now. So now our PFS is 1.9 months, but really versus almost 4 months with elacestrant. And again, this was statistically significant. I think what really stands out to me in these curves is that there's about half of the patients that are progressing at their first scan, regardless which arm they're on. These are patients that are really probably more endocrine resistant, but we don't have a great way of picking out who those patients are. Patients might have been on CDK4/6 for years. Their tumors may still be ER/PR positive. Maybe they even have ESR1 mutations, which are more common in patients that still have endocrine sensitive disease, but we don't have an assay to tell us this is still an endocrine sensitive tumor. And so I think this is still an unmet clinical need. So what about the other randomized data we have from oral SERDs? This is camizestrant. This, you can see they looked at 2 different doses of camizestrant, 75 milligrams once daily, as well as 150 milligrams once daily. And a similar design, this was also randomized against fulvestrant. And you can see that progression-free survival was 3.7 versus somewhere in the 7-month range with camizestrant, whether we're talking about 75 milligrams or 150 milligrams. Both arms here were statistically superior to fulvestrant. Now, you can also see that if we pick out those patients that have ESR1 mutations, we're getting into some pretty small numbers now, but we can, at least in the 150 milligrams, it looks a little bit longer. It doesn't really look that much different in the 75 milligrams, but I think this is probably sample size. So really, in summary, oral SERDs, elacestrant, camizestrant, et cetera, have demonstrated single agent activity in post-CDK4/6 tumors where we still have ER positive metastatic breast cancer. They have a pretty safe tolerability profile, maybe a little bit of mild GI toxicity, and this is a little bit variable from compound to compound. Some have a little bit more nausea and diarrhea, some have a little bit less, and fatigue. We also have a couple of unique side effects with camizestrant, asymptomatic bradycardia, where patient's heart rate is just a little bit lower than it normally runs. You stop drug and that goes away. And also something that we're calling photopsia. And this has created a lot of questions. This is not ADC IA toxicity where it's bothering the patient, really affecting vision. This actually just leads to when ambient light changes. So we're flipping on a light switch or we're turning off our lights at night in our bedroom, a little bit of waffling at the periphery, the very edge of the vision. And this lasts for a few seconds, maybe a minute, and goes away. So it's not affecting reading, not affecting driving, really not affecting quality of life. But again, that's transient. If we stop drug, it goes away. And so, regardless, patients do experience progression on these endocrine therapies. And so, we want to talk a little bit about PROTACs that take this concept of protein degradation a little bit further. So, let's dive into the PROTACs. These are hetero-bifunctional molecules that degrade the target protein, here the estrogen receptor, via the ubiquitin proteasome system. This can eliminate the target protein without an active site, since the activity actually depends on having a close proximity to the target. So E3 ligase comes in and binds, and then it ubiquinates the estrogen receptor, flags it for degradation, and spits it out. It's catalytic in its mechanism of action. So when a PROTAC is done with one estrogen receptor, it can move to the next molecule. And so this allows it potentially to be less toxic because we don't need to give it as high a doses and have a higher therapeutic index. We also can act iteratively again and target multiple copies of the target protein, and also able to really target some of these scaffolding proteins and signaling proteins that aren't traditionally thought of as really being accessible by conventional activators or inactivators. So what does this look like? Our PROTAC is our cute little rainbow molecule here. It's going in and binding our green blob, which is the estrogen receptor. When that happens, it recruits in our big blue E3 ligase, the monster as I call it. This leads to ubiquination, or these purple molecules hanging off the estrogen receptor. This tags it as foreign in the cell, and ultimately the proteasome comes in now and chews up our estrogen receptor and spits out our little green pellets on the other side. So some examples of PROTACs in clinical development, the one that is furthest along in development and that you probably heard about is ARV-471, now called vepdegestrant. And then we also have AC-699, which is currently in clinical trials. You also see that there are targeted agents against the androgen receptor being looked at in prostate cancer, and also some BTK targeted agents being looked at in B-cell malignancies. So this isn't a play with PROTACs just in the breast cancer space, although that's what we're focusing on today. So let's talk about the degrader in terms of ER positive disease. This is vepdegestrant, previously known as ARV-471. And this was our phase 1 dose escalation study that we presented actually a couple of years ago at San Antonio Breast Cancer Symposium. It enrolled patients regardless of whether they had an ESR1 mutation or not. And you can see there were no dose-limiting toxicities or any grade 4 treatment-related adverse events. In fact, we never reached an MTD. It was actually very well well tolerated. Most AEs were grade 1 or grade 2, and the clinical benefit rate was 40% among those 47 patients that had measurable disease on scans and were evaluable. We did see three partial responses. If you go over on the right, you can see the different colors representing different doses of vepdegestrant. And these little dots to the left show what patients' prior therapy or kind of characteristics of those individual patients and tumors were. So everyone had seen a CDK4/6 inhibitor. This is a little bit different, a little bit heavier pretreated population. Almost everyone had seen fulvestrant, upwards of about 80% of patients. Same with chemotherapy. And then you'll notice the line where there's only a few couple blue dots is those patients that had actually already received an investigational oral SERD. And you see some of those patients actually had benefit for 6 months or longer. So certainly looking encouraging here in phase 1 that was pretty heavily pretreated. This was the combination of vepdegestrant with palbociclib. Heavily pretreated ER-positive, HER2-negative metastatic breast cancer. Neutropenia was the most frequent adverse event. We would anticipate that from palbociclib. We know in the real world we see excess of 70% grade 3, grade 4 neutropenia. And here we actually saw even a little bit larger grade 3, grade 4 rates at about 89%. Vepdegestrant actually increases our concentrations of palbociclib a little bit, but also these patients were pretty heavily pretreated in a phase 1 population. Again, no DLTs, no grade 5 AEs. We did see a little bit of other count issues, platelet count decrease, anemia. We would anticipate that with palbociclib. And we saw the clinical benefit rate even a little bit higher here, 63%. About 3/4 of our patients had an ESR1 mutation, probably not surprising in a more heavily pretreated population. And we saw a median duration of response of those 13 responders of excess of 10 months. And the median PFS was 11 months. And what was really interesting is we saw this regardless of whether patients were ESR1 wild type in their tumors or had ESR1 mutations. So where is vepdegestrant going from here? Phase 2 cohort expansion of vepdegestrant, VERITAC trial was in a little bit earlier line setting. At least one prior endocrine therapy for metastatic disease, had to have had CDK4/6, and up to one chemotherapy. And they looked at 2 doses, 200 milligrams once a day and 500 milligrams once a day. So again, everyone had CDK, 3/4 of patients had fulvestrant, and about half of patients had had chemotherapy. What we saw was that 200 milligrams was just as good at 500 milligrams, and that robust estrogen receptor degradation was seen at both doses at about 71%. In terms of clinical benefit rate, if we look at all patients, this was about 40% of our patients. But again, similar to other trials, if we enrich for those patients that have ESR1 mutations, we're able to boost that to about 50%. And again, similar with PFS. PFS of about 3.5 months in all comers, but among those that had ESR1 mutations, even a little bit higher at about 5.5 months. Only 2 patients actually discontinued drug, and there were no dose reductions. So again, sometimes I kind of like looking at dose reductions and discontinuations to get a gestalt of how well the drug is actually tolerated. So this is the VERITAC-2 trial, very clean trial design, ARV-471 orally once daily versus fulvestrant, which really was our standard of care in the second line setting post-CDK. Everyone had to have had a CDK4/6 inhibitor, up to one additional line of endocrine therapy. And the most recent endocrine treatment needed to be given for at least 6 months. So this really weeds out the patients that maybe progressed on CDK4/6 very quickly, that really wouldn't be appropriate to continue to go on another endocrine trial, kind of learning from what we saw with Emerald with that half of patients progressing on the next line of therapy. No prior fulvestrants allowed and no prior chemotherapy. When these studies were designed, there wasn't an oral SERD commercially available. And right now, elacestrant is only commercially available for those patients with ESR1 mutations. And from what we're seeing with ARV-471, we have activity in patients that have wild type ESR1. So really a different population. It's currently being looked at in all comers, second line, not just those with ESR1 mutations. We also have VERITAC-3. This is vepdegestrant in combination with palbociclib, looking at first-line therapy. So really looking, instead of doing an AI and CDK4/6, could we do PROTAC and CDK4/6? And so you see we have ARV at 100 milligrams and also 75 milligrams lead-in, again, because we're actually seeing a little bit higher doses of palbociclib when we give it with ARV-471. We think about 100 milligrams is actually going to be the equivalent of giving 125. And then in phase 3, we're going to randomize letrozole palbociclib versus ARV-471 and palbociclib. So what about this second molecule? I'll tell you it's not called a PROTAC because the name PROTAC is trademark, but it is a very similar molecule. So they're actually calling this a novel degrader. You can see that it works in very similar way. We kind of bind the estrogen receptor here, bring them in close proximity. The E2 ligase, again, adds on the ubiquitination, flags it for the proteasome to chomp it up and spit it out. So according to this data, potential to have a little bit deeper ER degradation. You see over on the left a couple of different cell lines. You see fulvestrant, the AC0699 highlighted in green. And then you see a variety of the novel oral SERDs, fulvestrant as well as GDC compound, AZD compounds, et cetera. Over on the right, I think this is a little bit of an interesting graph, actually looking at the ratio of ER degradation versus fulvestrant. We see that some of these molecules have a little bit of SERM characteristics where they don't actually completely degrade estrogen receptor, but they can be kind of agonistic or antagonistic in different in different tissues. But you can see here that the chimeric degrader all the way on the bottom, really across these three cell lines, are very clearly complete degraders. Our vertical red line here is where fulvestrant falls, just for reference. So what does the AC699 trial look like? This is currently in a phase 1 trial, again, an ER-positive, HER2-negative metastatic breast cancer. Patients had to have received at least 2 prior lines of endocrine therapy, or if they had endocrine therapy in combination with a CDK4/6, they can enter after 1 line. You can see that there's a few dose levels, 100 milligrams, 200 milligrams, 300 milligrams, 400 milligrams. Again, it's oral daily dosing. You can see that the majority of patients coming in did not have an ESR1 mutation. About a third did. And in terms of prior regimens, the median is 5, pretty heavily pretreated. Everyone had seen the CDK. And then in terms of a prior SERD, circa, or a different ER chimeric degrader, such as ARV-471, almost everyone had seen this and how it broken down. Most patients had seen fulvestrant, 80%, a prior SERD or circa at about 15%, and 3 patients or 10% of patients had seen a prior chimeric degrader. Almost everyone had seen an AI, over 90%. And so this is the data that has been presented so far. Blue at the top is 100 milligrams, green is 200 milligrams, orange is 300 milligrams. And you can see we had a partial response at the very first dose level at 100 milligrams. You can see that the little green triangles are partial responses. Orange is stable disease, and really a quite clean side effect profile. You'll note that any grade 3 or greater side effect is less than 10%. Fatigue, only 1 patient reporting that. And even if we look at all grades, which in a phase 1 population, we certainly do see a lot of grade 1 and grade 2 adverse events, our side effects are kind of 20% or less. Again, really telling us that this is probably a pretty well tolerated compound. So overall, we saw responses in 20% of patients, but if we look at just those patients that had ESR1 mutations, this is actually 50%. And then in terms of clinical benefit rate, 29%. And again, if we enrich for ESR1 mutations, 56%. PK profile showed dose proportional exposure up to 400 milligrams. There are additional studies being planned, and I show you kind of the depth of the responses over on the left, where you can really see that it was those patients that had ESR1 mutations on the far right side of this graph that were really having substantial tumor shrinkage. So again, where are we going? We have the phase 2 trial of neoadjuvant vepdegestrant versus anastrozole. We have VERITAC-2 as well as VERITAC-3 that we've gone over. We also have a phase 1 trial looking at vepdegestrant in combination with everolimus, our mTOR inhibitor. Everolimus needs a new partner compared to fulvestrant, and so we're looking at that. And then there's also an umbrella trial really looking at combining vepdegestrant with other CDK4/6 inhibitors, for example, ribociclib and abemaciclib, and AC699 is still in phase 1 clinical trial at this time. The other place that I'm particularly excited about these novel compounds is actually in the adjuvant setting. We wouldn't be using aromatase inhibitors adjuvantly if we had gotten the dose of fulvestrant right. I think that there is definite play to maybe optimize therapy for those patients that are higher risk in the ER-positive adjuvant setting. So I show you this just to tell you that we're going to be hearing more about PROTACs. These are all the places that PROTACs can go. And to give you a couple of teasers, ClipTac is the orange on this graph. This is 2 small precursor molecules with the ability to click intracellularly, enabling transfer through cellular membranes more easily than one large PROTAC compound. There's photoprotacs in this kind of yellowish orange color. They're trifunctional molecules. They have the ligand for E3 ligase. They have the ligand for what we're interested in. And then they also have a photo switch. So they're inactive in the dark and can become active under blue-violet light. And then we also have antibody PROTAC conjugates, not ADCs, but APCs. And so this can selectively deliver the PROTAC to antigen expressing cells. So for example, a trastuzumab PROTAC conjugate. So we could maybe be targeting those cells that have HER2 signaling. So very exciting. So in summary, the novel estrogen receptor degraders, PROTACs, are active even in patients that have seen prior oral SERDs and certainly active in patients that have seen prior fulvestrant. Targeting the estrogen receptor remains a really high unmet clinical need. We know that our patients need better endocrine therapies post CDK4/6 than what we currently have available. We currently have one oral SERD approved with elacestrant, but that drug is a little bit more SERM-like than SERD-like. So I'm particularly excited to see some of these other compounds coming. I do think that PROTACs are different. They seem to be a little bit better in patients that have some underlying endocrine resistance. And that's such a huge problem. You know, in that emerald curve, you see about 40 to 50% of patients, despite the fact that they, did well on CDK4/6 progressing. And so I've been pretty impressed, patients that maybe haven't had as much benefit to endocrine therapy in the past, doing very well on PROTAC. And so I kind of do think that they're going to be quite active. And it's a pressing clinical need to identify which patients are appropriate for continued estrogen blockade and are likely to respond to these treatments. We need to get smarter in terms of the individual patients and personalizing our therapies beyond just using ESR1 mutation, which in my opinion is a pretty poor surrogate for really endocrine sensitivity. Thank you so much.